Hey, hey, period party people. Thank you for being here for another week of Women's Health Talk. I mentioned this in the last episode, but wanted to share a reminder that this is the last week to apply for my Women's Hormone Health Certification program that kicks off in early October. If you are a health coach or practitioner, or you're currently training to be one, and you're interested in in depth women's hormone health training complete with live calls, case studies, extensive done for you protocols, and so much more, then take a look at my Women's Hormone Health Certification program. You can find the details and the application form for the course at instituteformenstrualhealth.com or email me at hello@nicolejardim.com with any questions. Okay, in this episode, I am honored to speak with Dr. Anne Peled. She's an internationally renowned breast cancer and plastic surgeon based in San Francisco and a true pioneer in the field of breast cancer surgery. Dr. Peled's journey is one of resilience and dedication, having overcome breast cancer herself and then dedicating her career to empowering others facing this challenging diagnosis. We explore her innovative work, particularly the life-changing nipple and sensation-preserving mastectomy technique, which is transforming the landscape of breast cancer surgery and enhancing the quality of life for countless patients. Dr. Peled shares her personal experience, insights into breast cancer treatment options available today in the US, and her commitment to educating both patients and healthcare professionals in this deeply informative and inspiring conversation. Don't forget to leave a comment or feedback on the video, leave a rating or a review on Apple Podcasts or Spotify, or find me on Instagram and send me a DM. Thank you for being a part of my podcast community, and I look forward to hearing from you. Hi, Anne. Thank you so much for being on the podcast with me today.
Thank you so much. It's such a pleasure.
Yes, absolutely. As I was saying to you before we started recording, this is all very new territory for me, and I'm really excited to dive in because I feel like you have a ton of knowledge and personal experience to share.
I'm so glad that you think this is something that people would want to listen to and really love talking about all these parts of breast cancer treatment and other advances and all that. So thanks for having me.
Oh, for sure. So I figured we would start with your personal journey and your experience with breast cancer and how all of that influenced your decision to pioneer this new mastectomy technique.
Yeah, thanks for asking about that. I think it's really shaped so much of this. When I was 37, I felt a breast lump, and I tried to do what I tell my patients to do, which is, don't worry, but if it's still there after a couple of weeks, to go get it checked out. And I went in, I got it biopsied, and I have to say, when the pathologist called me the next day and told me it was invasive breast cancer, I was blown away. I had no family history. I'm a vegetarian. I'm a triathlete. I mean, like many of us, just floored when these unexpected health things come into our lives and how disruptive it is. But honestly, feel incredibly lucky that I found it early. I was able to have, relatively straightforward treatment with a lumpectomy, oncoplastic reconstruction to help fill in the space from the lumpectomy, and radiation. And I've been on hormone blocking therapy now for about 5 years. So for me, again, like so many people after the initial shock, it really was trying to take one step at a time, figure out my treatment options, and then use that experience to figure out how I could transform care for other people in my situation who were diagnosed and were overwhelmed with the different options and how difficult it was to make a surgical decision, particularly.
Yes, I know. I don't know. I truly can't imagine. I have a few friends who have recently been diagnosed over the last year or two. And honestly, I didn't realize that breast cancer diagnosis under the age of 40 was as high as it is. I'm shocked because all of them are under the age of 40. And maybe I'm just imagining this. Is this a new thing? Is it now becoming more common under the age of 40 or in your 20s and 30s?
It really is. And you're not imagining it. We do know that breast cancer affects 1 in 8 women in general, kind of lifetime risk. But I have to say, I have lots of patients in my practice in their 20s and 30s, and we don't really know yet what is causing this. I wish we did, of course, so we could do something different. But what I will say is, wonderfully, if we catch breast cancer early, even in younger women, it's still incredibly treatable. And so the message I always say, if you have a breast lump, go in and get it checked out, because women in their 20s and 30s usually aren't getting breast cancer screening. They're not getting the routine mammograms we recommend starting at 40. So it's really important that people here, go in, and sometimes people get pushback, right? It breaks my heart when I hear women in their 20s or 30s are told they're, quote, too young to get breast cancer, and maybe things get pushed off. So, hopefully that's a situation where people feel strong in advocating for themselves to push forward and get them worked up.
Oh, yeah, for sure. I mean, hopefully they're listening to this, and this is a helpful clue for them to, start to think about this, because like you were saying, if there's not any history of it in your family, like you were describing with your situation, why would you even think that this is a thing that's potentially happening to you?
And most breast lumps are not breast cancer. I think that's the other thing that's really important for people to hear, because it is terrifying, right? We do hear a
Yeah.
lot about breast cancer. We hear about celebrities getting breast cancer. Sadly, we hear about celebrities dying of breast cancer, and it's out there, but most breast lumps are benign. So the idea is, don't be overwhelmed with the fear of going in, but if you do get it checked out, most of the time it's going to be nothing. But if it is something, now at least you're on a path to getting it taken care of. Well, hopefully it's early and highly treatable.
Yeah, for sure. Is there a point where it becomes untreatable, or it's significantly less treatable? Like, what is there a stage of breast cancer?
So when we talk about breast cancer that's spread to the rest of your body, we call it stage 4 metastatic breast cancer. And
Mhm.
even in that space, we've actually made incredible strides in the last decade or two. So even though we think about that as technically untreatable breast cancer, there are many people who live for decades with metastatic stage 4 breast cancer that's being treated. It's certainly something that takes work. It's like a chronic disease in terms of the management. But again, even in that setting, for people who do have cancer that's spread outside of their breast, it doesn't mean that they have, months or even a short period of time to live with it. Many women live a very long time, even with stage 4 breast cancer.
Okay, yeah, that's so helpful to hear. And so, as I was saying earlier, you've pioneered this new mastectomy technique, and I would really love for us to talk about that. So, can you maybe explain in easy terms how this technique, works, and just how it differs from a traditional mastectomy?
Yeah, I think to kind of tell the history of where we got to this, I like to use my own story as an example of when I was diagnosed at 37. My hope was this was early stage, and I had many, many years to live with my breast and myself. And, I had gone from a situation where the day before I had all my body parts were intact and I wasn't thinking about the impact. And when I got diagnosed, I kept thinking about my friend who had had breast cancer a couple years before, and she had a double mastectomy, a traditional mastectomy, where all the nerves are cut. And she said she put on a sports bra and didn't feel it was on. And I just sat there thinking, there's so many components to it. There's the sexual piece, there's the femininity piece, there is all of it. But just the thought that I was going to have this huge swath of my body be so numb that I didn't know a piece of clothing was on, especially as an athlete where I was wearing a sports bra every day to work out, I just couldn't do it. And so I ended up having a lumpectomy for one of the main reasons, because I just couldn't comprehend at 37 being numb for the rest of my life. And so my husband is actually a peripheral nerve surgeon. So he treats nerves all over the body as his day job. And we were literally sitting talking at dinner about how we couldn't do a better job keeping nerves in the breast during mastectomy and reconstructing them the way we do in other parts of the body. Let's say if you've had a hand injury and you've cut nerves there. So actually, I had my breast cancer surgery in January 2018. And a month later, my husband and I did our first, what we call sensation preserving mastectomy, with the idea that rather than just cutting through all the nerves in a mastectomy like people usually do, we try to look for the nerves. Together, he wears these little glasses in the OR that are like mini magnifying glasses. And together we look and we say, are these nerves that can be saved and still remove all the breast tissue? Because it's so important to still take out all the breast tissue when you do a mastectomy. Some people have nerves that run under the skin. We keep those, we save them. Fantastic. A lot of people have nerves, though, that run through the breast tissue, so we have to cut them. And then what we do is actually in the same surgery, reconstruct them, either using extra nerves in the breast that would have to be cut anyway, or using actually nerve grafts that come off the shelf. So what happens is we're doing these nerve repairs, we're saving these nerves at the time of mastectomy. At this point, I think we've done over 800 of these sensation preserving mastectomies, and it's really remarkable to see how much sensation people get back in their breasts that's so dramatically different than that completely numb chest like you've had, lidocaine at the dental office. So it's really been, again, an amazing thing to come out of this diagnosis that no one wants, but makes me so happy that now people have different choices than I had when I was diagnosed.
Yeah, this is huge. When you said the lidocaine thing, I immediately thought of a dental surgery I had last year and how completely weird that feels. So that is literally what women are feeling like pretty much all across their chest after a surgery, that lidocaine feeling.
It's the lidocaine feeling, and it can go all the way from your collarbones down in many people to their belly button. So it's a huge area. But to make matters worse, when you injure nerves, you don't just have the numbness that you have, like your whole face is numb from the dentist, you also get chronic pain. So
Oh,
people form balls of scar at their nerve endings. So if you ask people, and it's a high number, studies say it's as high as 50 to 80% of people who have traditional mastectomies have either chronic pain or numbness or both. And it's this sort of terrible combination of you're numb everywhere, but then you also have stabbing pains inside. And it's really hard to watch people who've gone through mastectomies either because they had breast cancer or because they have a really strong family history or a gene, and they're trying to proactively reduce their risk of breast cancer. And yet here they are having gone through the surgery to try to change their lives, and now they're left being completely numb or in pain for the rest of their life. So we're really trying to change that so that people can at least feel as positive as you could be in that setting about having this risk reducing surgery to try to reduce their breast cancer risk.
whoa. Okay. I clearly did not know this. I have a sister-in-law actually who had a traditional mastectomy, and now I have to ask her a million questions. She never really talked about all of that. So I just had no idea. I just feel like obviously, for me, and I imagine for a lot of people, getting any kind of cancer diagnosis just seems terrifying. And for me, mostly it's because, I don't really have any experience with cancer. I have some people who've had breast cancer or been diagnosed with it. And then I mentioned my sister-in-law, but no one else in my family or close to me has had it. So I don't really know how the process works or like what the next steps are. I know that you've talked about your approach being rooted in this shared decision making with your patients, especially when it comes to discussing all these treatment options and obviously the potential impact on their quality of life, which makes sense now that you've described all of this. Can you maybe give a little bit of a breakdown about what happens when someone is diagnosed with breast cancer and what the steps are with you particularly?
Yeah, and I love that you're asking about that because I think the reality is people hear cancer, especially breast cancer, and the initial thought for everyone is just get it out of me as soon as possible. And that is
Right.
so understandable, right? And what
Yes.
happens though sadly is a lot of these things you can't take back, you can't undo. So even though we are able to really in some cases go back and try to repair nerves and try to fix things people have had traditional mastectomies, the very best time to have the best outcome is in your initial surgery. So one of the things I say to people always is take your time after you've got diagnosed. I'm not saying take months, but this is the time to do your research. I love, love, love when people get second or third opinions because you get more information, you get the right fit for you, you get to find a team that feels like they're listening to you. And that's where the shared decision making comes in. I always say when I give talks, feel so lucky to be a breast cancer surgeon, a breast reconstruction surgeon, and a breast cancer survivor in this day and age because people live so long after breast cancer diagnoses. So because that's the case, now we're really focusing on these quality of life issues. So what I say when I have someone who comes in who's newly diagnosed, like let's say you've got time. Let's say you've got weeks, you've got time to make this decision. What's going to matter to you in a year from now or 5 years from now? Because when you're in it, you're right here. All that matters right now is you want to survive. And wonderfully, most people are going to. So now it's more what matters to you 5 years from now. Are you incredibly active? For me, one of the types of breast reconstruction is using your own tissue from your belly. It's a great option for some people, but it cuts through part of the muscles. And for me, I just can't do that. I'm too active. It would be too much recovery. It would be too much. And I know that about myself, but you don't know that about your patients unless you ask. And so what I always say to people is one, try to find a breast surgeon who really feels like, yes, they're treating your cancer, but they're also asking you questions. They're getting to know you as a person, getting to reassure you that you have time, helping you with a decision that's more than just, let's take out the cancer.
Right.
I think the next piece of it is also making sure that you're aware of what's out there. So we always say you don't know what you don't know in healthcare, right? And it's so scary to hear people who don't know that things even exist, because oftentimes as providers, we're kind of guilty of telling people what's in our toolbox and not necessarily offering them things that aren't in our toolbox and have them go somewhere else. So I think being online in communities, listening to podcasts like this, engaging in social media and other communities, it allows you to see what other people are having. And if your surgeon didn't offer you that, it allows you to go back and ask. And if they still don't offer it, then it's time for another opinion, and really make sure that you're getting all the options for you. So again, it's taking the time after diagnosis to give yourself that permission to get all the choices and hear and find your right team.
Okay. Yeah, that's super helpful. I know I was thinking about that. Like, how much time do you really have? So it's good to hear the timelines. I was thinking about this, about informed consent or fully informed consent, and that comes up so often in the work that I do, particularly around things like birth control and various other things where you have to make a decision, but you have to know the facts too. And I feel like obviously that's so pertinent in a conversation like this when you've been diagnosed with breast cancer, or really any condition. So, um, with regard to that, like, do you have any additional advice for women who are dealing with a breast cancer diagnosis, or they've been newly diagnosed and they're considering these surgical options? Is there anything else that they should be considering in addition to what you were just saying, like
Yeah,
how
so
they
the
can
kind of
advocate for
questions,
themselves?
yeah, for sure. The kind of questions that I like to have people ask if they can. I think the first one is to say, what are the advances that you are pioneering or providing in your practice? Or what do you think are kind of the biggest advances in breast cancer surgery right now? Because things are changing all the time. And if you're with someone that doesn't have any great answer to that, or is offering you, we say your mother's breast cancer treatment or your grandmother's breast cancer treatment, again, that's a good sign that this isn't someone that's even up to date on what the latest advances are. And so you probably won't be getting them. I think the next thing that's really important is to ask if you can either speak to other patients who've gone through similar surgeries, ask if you can see photos of what people have gone through. Again, people often feel after a cancer diagnosis like these things are cosmetic. Where are your scars going to be? How are you going to look? But it's not. It's a daily reminder every single day that you had cancer if you have a huge, terrible lumpectomy scar across your chest. And so asking where your scars are going to be, you're the only person who wakes up in your body every day, and you deserve to know how you're going to look and feel afterwards. And then I think the last thing is just giving people permission to question your healthcare team a little bit. We often feel, again, I'm guilty of this as a patient myself sometimes, they're experts. You don't want to push them. What if, you make them feel bad? Will they not take good care of you? All those questions. But again, ultimately, the very best healthcare provider for you is someone that allows you to ask these questions about how you're going to look, how you're going to feel, what are the other options, what else might be out there, and supports you in that. And I really feel like if you don't have someone who supports all of that, that really probably isn't the right person for you. And it is okay to go somewhere else if you're not getting those answers, and being able to advocate for yourself and feel supported in that.
For sure. I know. I think it can feel so intimidating when you're chatting with a doctor and they're the expert, they know it all, and to come in with confidence, it feels hard. I think, just in my experience with a lot of clients over the years, it's challenging to be able to advocate for yourself, especially in a situation like this.
It's really hard. And it's also hard because I think, again, I know that you see this, I'm sure, in other parts of women's healthcare in general, but some of the stuff we're talking about, they're not areas where we've been supported as women for a long time, right? So sensation is a great example. It's much easier to kind of advocate, well, I don't want to be totally numb, or I don't want to have chronic pain, than to say, which I hope people will, nipple sensation is a really important part of intimacy for me. And I really don't want to lose that. And I think, again, especially as women, that's not an area that we've ever really been told we get to talk about. People don't feel comfortable. It's very intimidating to say those things. But again, that really matters. And giving ourselves permission to find someone who's willing to have those conversations and feel supported, it's really hard. But again, I think being parts of online communities, and I love it. I just got back from a camp with an organization I work with called the Breasties. And it's a bunch of primarily young women affected by breast and gynecologic cancers. But it's so fun. I mean, people take photos showing off their reconstruction. People talk about these things. I went to an amazing panel on sex and intimacy. So these are the kind of communities, if you can belong to, it feels normalized. It feels normalized to talk that nipple sensation matters to you, and it's going to matter how your body looks and what that looks like in sex and intimacy. So I think finding your people is incredibly important so that you do feel empowered in that space.
I could not agree with you more. This is totally off topic, but very similar. Late last year, I went to this place called the Omega Institute. It's a retreat center in the Northeast here in the U.S. And so basically, it was for this psychic medium, and she communicates with people who've passed. And for everyone who's going to ask me questions about this later, I can answer them, but don't think I'm a weirdo. But it was one of those things where you're in this room with hundreds of people who've lost someone really close to them, and not everybody can really relate to that. And it's just so normalized to be able to talk about the person who's died, or your loss and your grief, and all of these things that we just don't talk about in our society at all. Because I know there are not a lot of women who are talking about their mastectomies and the symptoms and the side effects that they experience. So I feel like it's another taboo or off, like not comfortable subject to talk about. So it's
That's
totally
a
different, but the same.
example. But it's the same.
Yes.
It's that concept of being in a room where you feel like the questions you're going to say, no one's going to judge you. No one's
Yeah.
going to think you're weird. And again, that space, I have to say, being in these rooms of people who've gone through this as a survivor, as a patient, it's one of the few places I give talks all the time to other surgeons. And I love it. I love educating people. I love hoping that we're going to advance the field. But my favorite place to talk, honestly, is in rooms of survivors, because I feel like I can say all like, let me tell you the crazy thing I did during radiation oncology that I'm sure my doctor's like, oh, why? Those are the places where you feel safe. And so I think that's a perfect example of like just a room full of people who get where you are and aren't going to judge you.
100%. I know, right? You could say the craziest thing and everyone's like, yeah, girl, totally understand. Yeah. So I would love to come back to the surgery though. So I'm curious about a few things. The first is what the stats are on your surgery versus the traditional mastectomy in terms of preserving sensation, and I know there's like nipple preservation as well. Can you talk a little bit about that?
Yeah, so I think kind of the big first step is really the idea that for many people, nipple sparing mastectomy. So the idea that we keep all the breast skin and we keep the nipple and what's called around the edge of the nipple is called the areola. We keep all that skin. So a lot of people say, well, how can I safely have that? Aren't you leaving breast tissue behind? And the reality is all mastectomies leave a little bit of breast tissue behind. It's just inherent. We can't get every single cell. But with nipple sparing mastectomy, the idea is we're taking the breast tissue as it goes up into the nipple, and all of that is coming out. So we
Mm.
know in big studies that that is a safe thing to offer, whether you have cancer, whether you have a genetic mutation like a BRCA mutation like Angelina Jolie has, that increases your risk of cancer. So that's the first thing, is kind of the idea that you can advocate for that. And that isn't a technique that all surgeons even know how to do or offer. So that's kind of my first big thing that I often educate people is ask about nipple sparing mastectomy. But then in big studies, if you look at standard nerves getting cut, nipple sparing mastectomy, only about 15 to 20% of people max have any good nipple or skin sensation after their surgery. So the idea that we're keeping how the nipple looks is wonderful, but if you can't feel it, it doesn't play a role in intimacy, it doesn't respond to temperature, all of that, for a lot of people, it just feels a little unnecessary that you've kept it. So what we try to do is to do a twofold approach where we're trying to keep and reconstruct nerves to help with the skin itself, and then also directly repair nerves to the nipple, so that people kind of get this sensation that grows out from the nipple over time, grows from the sides of the breast, and so they get kind of sensation throughout. That process for most people takes about 6 months to a year. It can be a little longer in people who have larger breast, people who are getting chemotherapy or radiation kind of slow down nerve healing a little bit, but ultimately it works. So we track people very closely. As I mentioned, we've done about 800 of these mastectomies now, and we find pretty consistently close to 90% of our patients get back most, if not all, breast sensation. I definitely have patients that send me fun messages being like, oh, I went running today and I just felt exactly like myself. Or people telling me stories of how their breasts still play a huge role for them in intimacy, that they can be intimate with partners and enjoy nipple stimulation, and that that feels good to them, which is definitely not true for standard mastectomies. So I think we see, again, most people are going to get back most of their sensation. I do like to tell people that a lot of times it's not completely normal sensation. So again, hopefully you get lucky and you really do feel completely back to normal. For most people, it feels a little bit muted from before, but you still feel everything. You still respond to temperature and touch, which again is dramatically different than a standard mastectomy.
Yeah, okay. That's so incredible. I wanted to ask you about implants versus no implants. I feel like there's a lot of conversation these days, at least in the more holistic world of women's health, around breast implant illness. And so I'm just curious, like, what your thoughts are on the implant versus no implant, or using fat. I believe there's like, you can also use fat as well, I think, for the breast tissue, or to replace the
Yes,
breast tissue.
there are lots of great options for breast reconstruction. So it kind of starting to begin with, one of the things that we do now, which is fantastic, is actually a lot of people are choosing not to have a formal breast reconstruction, but they don't want to look deformed or kind of indented, concave. So what we can do is something called aesthetic flat closure, which is a huge thing where we actually reshape kind of the skin in a way that makes your chest look flat, or even gives you a little bit projection, but doesn't look deformed. And so honestly, it's a big thing that a lot of people are choosing now to not have any formal reconstruction. It's a faster recovery. It's relatively straightforward in terms of how you heal. Again, you don't end up having any formal projection in most cases, but a lot of people are really fine with that. And you see it all over social media now, this movement kind of to show off how people look and owning how people look in that setting. And I love that. So that's a great option to just begin with. And a lot of practices don't talk about this. They just make the assumption that people want to have breast reconstruction, and not everyone does. So I think that's the first thing to kind of think about as a choice. But then if you do want to have kind of a breast projection, have a more kind of standard breast reconstruction, we have a couple of different options. One is to use breast implants. The newest generation of breast implants, we've got good data on the safety. There are these so-called gummy implants that you can cut in half, then the silicone doesn't go anywhere. So kind of the concerns we used to have around implants leaking or spreading over the body, we wonderfully don't have that anymore. And I will say, I think breast implant illness is a real thing. We definitely have people who feel like their implants are making them sick. But I will say, putting in hundreds of breast implants every year, I can count on one hand and probably two fingers patients I've put implants in, so that's the last 7 years, that really feel like their implants are making them sick. So I do think implants are safer nowadays. And I think that that we do have good options in that setting if that's a choice you want for reconstruction or augmentation. But
That
then
is so good to hear. Yeah.
no,
I didn't
I
know
always
about
tell people
that.
that.
Yeah.
I'm like, I would have breast implants if I had gone through mastectomies. I would have had implants and felt very safe about them. And so I do think that it's a good option for many people. But then if you don't want to have implants, because again, it's a strange concept for some people to have a foreign material in their body, even if it's safe. And so then we can do one of two things. One is we can use tissue from somewhere else in your body. So it's usually kind of the lower part of the stomach, sometimes the thighs or the back. And we can actually use that and connect it to little blood vessels in your chest and make new breasts. So that's what's called flap reconstruction. And then the final thing is kind of a hybrid where we do liposuction from one area of the body. We process the fat and make it in little kind of special ways of the very best part of the fat. And then we distribute it into the layers. So sometimes that's done as a primary reconstruction for women who want to be pretty small. Sometimes it's an adjunct to kind of help smooth out edges if you've had implant or flap reconstruction. So we have kind of amazing technology now, and it keeps getting better. I mean, we have scaffolds people are talking about where they're going to put your own fat in. I'm sure there's 3D printing coming. So it's really, a lot is changing. And I think if we were having this conversation 5-8 years from now, it would be a totally different ballgame in terms of what the options are.
Whoa. Okay. Wait, talk to me about 3D printing. What might happen there?
Yeah.
This is
So, I mean, they're
fascinating.
really, exactly. So what they're looking at is ways that they can put in some kind of scaffold where your own tissue will grow into it, or you could potentially augment that growth using fat cells. So doing a little bit of that liposuction, adding some fat into the scaffold that will then get incorporated by your body.
Wow.
Yeah. So very like, wouldn't have to have formal implants, wouldn't have to have the big recovery of the flap, like I mentioned, and that would be an amazing hybrid. So sometimes I have people ask, which is a question I love, do I need, let's say you have a gene mutation that increases your lifetime risk of breast cancer, but you're 30 and you're thinking, my lifetime risk of breast cancer is 60% by the time I'm 70, but do I really need to have a mastectomy now? And I love that question because it gets me to talk about what are we coming up with in the breast cancer world? So I think the first thing to think about is breast cancer vaccines. So this is happening. There are trials of breast cancer vaccines right now for more advanced, more aggressive breast cancers. And those are the kind of things we should have data in a couple years. So what if we get to the point that for the most aggressive breast cancers, we actually can do vaccines to avoid people getting breast cancer? That would be incredible, right? Both in terms of treatment, but also people at high risk. Then we have these reconstructive options where, let's say you can have a nipple sparing, nerve sparing mastectomy and not even have to have a foreign material or a flap and literally have something off the shelf that's your reconstruction. So I think all of this is coming. And I do think for people considering risk reducing mastectomies, it's a really good opportunity to look at your own family history and risk. If you're someone that has a lot of young breast cancer, maybe you are someone that should think sooner rather than later about doing a prophylactic mastectomy. But if you're not, maybe it's a time to wait it out, have your screening, get checked regularly, but wait it out for some of these advances because we might be in a very different place. I hope all the time I don't have a breast cancer surgery job. All the time I hope that, this is the year that I will no longer have that part of my job. And I think that it's not that far off that we're going to have much better options.
Okay, this is all fascinating. I had no idea about the vaccine. So I'm so curious about this. So you had mentioned earlier that I know there's all kinds of potentials about why one might be getting breast cancer and getting it earlier and all kinds of things. How do these vaccines work if we don't totally know how we're getting breast cancer?
Such a good question. So basically what they're going to try to do is, so they're specifically looking at certain receptors, certain types of receptors or lack thereof that show up in more aggressive breast cancer cells. And they're using some of the information we've learned from immunotherapy treatments to think about actually kind of in some ways affecting the immunologic response to some of these tumor growth factors. So it's kind of like you said, there's always going to be environmental factors, but is there a way to actually change these tumor growth cells in a way that they don't go to those next steps to have uncontrolled growth that leads to breast cancer in specific settings? So it's a very targeted way for certain kinds right now. But it would kind of be to overcome some of those environmental factors. And then the genetic piece of it, though, is also part of it, right? And so we are seeing, which I love, that more people are learning about their family history. They're getting more genetic testing. They're knowing their risk and thinking about where they are. And that allows people to think, well, am I someone that maybe thinking about a vaccine might make sense when it comes down the road because my risk is really elevated? And even if it's not perfect, what if it brings it down significantly? So I think these are all these kind of questions that in the next few years, we're going to be looking at and figuring out more and more.
Okay. Yeah. I mean, you've completely blown my mind. I feel like I knew maybe 2% of everything you've talked about today. I had no idea. Can you talk a little bit more about these techniques that you and your husband have pioneered? So I know that you teach other doctors as well. So do you feel like this is now really becoming more accepted as an option for women who have breast cancer? Or do you feel like it's still, it's not as well known?
So people often ask, we've been doing this now for 5.5 years, and people often say, like, why hasn't it become the true standard of care? And I think what's exciting is that it feels like it's at a real tipping point. I just gave a talk at our National Breast Cancer Society meeting, and 20% of the people polled in the audience said they're starting to do this. So in my mind, once you hit 20%, like you're at a place where many people are going to live in communities where they have this possibility, or not that far from them, they have this possibility. And once that happens, once enough patients start asking their surgeons about it and then going to other practices because they can't get it there, that's really what often makes that tipping point to make it truly become standard of care. So we do teaching courses, we give talks all over the world at this point. We've been starting to work with surgeons in other countries, which is exciting because other countries don't always have all the access to all of the technology that we have here. We're very lucky here in the US to have access to a lot more technology. So it's definitely coming. And I hear all the time from surgeons how excited they are when they implement this into their practice, because it really is truly game changing. I mean, I always think about, I have one of my most favorite patients who lost her mother when she was really young to breast cancer and decided in her early 20s, she really, really didn't want to go through breast cancer screening anymore. She had a gene that meant she was going to have an increased risk, and she just needed to be proactive. And she wanted to have mastectomies, but it was really scary early 20s. It's scary at any age, but it's really scary early 20s to think about going through a double mastectomy, being totally numb. And She tells a story all the time that being able to kind of keep sensation was one of the main reasons she was able to feel good, if you will, about going through this. And now is a couple years out, doesn't get screening anymore, has taken a ton of that health anxiety off the table about worrying, when is the bomb going to drop, that the MRI gets called and told you have breast cancer. So I do think for so many surgeons, seeing what it feels like to truly change the course of people's lives by offering this makes surgeons more excited to do it. So it's really just our continuing to be out there talking about it, surgeons being willing to implement it, and patients being willing to ask for it.
Oh, for sure. I know. I feel like you're at a tipping point almost where it's going to start to really blow up. Coming back to the gene side of things, can you just speak a little bit about that? The different types of genes that predispose you and what that increased risk is? Because you mentioned this younger lady, and I feel like thinking about that, just contemplating that in my early 20s, I can't even imagine it.
Yeah, no, it's pretty remarkable. They actually have really interesting, I think, and good data on this concept of an Angelina Jolie effect. And truly, after she announced that she had had double mastectomies and got genetic testing and found out she had this BRCA, is the abbreviation gene that increased her risk, a lot more people were up for genetic testing. We also have access to genetic testing. So you can get out of pocket genetic testing for $250, which is still money, but it's all things considered relatively low to get to have that much information about your health. And some genes, like the BRCA gene, actually increase your lifetime risk of breast cancer as high as 60 to 80%. So if you know you have a 4 out of 5 chance of getting breast cancer in your lifetime, you're much more likely to think about things like double mastectomies, and certainly to be really on top of your screening. So in that setting, we recommend starting alternating MRIs and mammograms, sometimes as young as 25 or 30, in terms of when people should start doing it. So I think knowing your family history and getting a sense of, are you a person that does have breast cancer and multiple family members, or ovarian cancer, or pancreatic cancer is one a lot of people don't know about. If you have a family member with pancreatic cancer, that can go with a breast cancer gene. So it's important in those settings to really talk to your primary care doctor or gynecologist about your family history of cancer and think about doing genetic testing. But there's a real range. So some of the genes, the lifetime risk is about 20 to 40%. And then again, some is as high as 80 or 85%. So I think getting that, I always say knowledge is power about these things. Once you have the information, it allows you to decide how proactive do you want to be? What kind of screening do you want to have? It's scary, right? It's scary to go through genetic testing and get that knowledge. But once you have it, at least you can be empowered with it.
Right. And then what about risk of other cancers? I know you mentioned a few others just now. Are there higher risks of, like, even if say you do the prophylactic mastectomy, are you at higher risk of having other cancers, like you said, uterine cancer or something like that?
Yeah, so with the BRCA, for instance, is a good example. It's the most well-known. There are 2 genes. There's a BRCA1 and a BRCA2, and they're both different kinds of genetic mutations that have different types and risks of cancers. But they can be associated with ovarian cancer. They can be associated with melanoma, pancreatic cancer, prostate cancers. There are some that are associated with gastrointestinal cancers. So I always ask patients, if they do find out they have a higher risk of cancer from a genetic mutation, if they can, either we help coordinate or they go to a high risk team that actually lets you get in touch with multiple different specialists. Because it's really nice to have coordinated care to make sure you are getting, let's say, your skin cancer screens, or they have new screening for pancreatic cancer and things like that. So it, unfortunately, there's a lot of kind of discussion in this world, this breast cancer world that we're in, that, people who are called what's called previvors, which is the term instead of survivors, it's the term for people who find out they have high risk and go through these prophylactic surgeries and screenings. Sometimes people get pushed back, like, oh, your stories aren't as important as those with cancer. Quite honestly, finding out you have a gene that increases your risk of multiple kinds of cancers is incredibly traumatic for many people. And a lot of times that's a place where people need even more support to get through those journeys, get the right team, feel supported. So I think it's, again, we kind of need to all understand that whether it's a cancer diagnosis or high risk of cancer, it all can be really, really difficult, and at times to seek support if you need it.
Yeah. Yeah. I'm just thinking about that. And I feel like, how do you make a decision to do that? Is it mostly women who have family members, like you mentioned, the person whose mother had died of it? Is it typically in a scenario like that, that
Yeah,
someone
so
would decide to do that
there's
genetic testing?
yeah, Exactly. There's screening guidelines. So the National Comprehensive Cancer Network, the NCCN, we call it, has cancer guidelines. I put a lot up also on my website and on my Instagram page and things, but basically it has guidelines around who should be tested. And the short story is it looks at things like, do you have multiple family members, let's say, with breast cancer? Or do you have family members who are diagnosed young with breast cancer? So let's say under 30 or under 40. But then it's things like, for instance, being Ashkenazi Jewish, there's a much higher risk of getting and having a BRCA mutation. So if you're Ashkenazi Jewish, they actually inherently recommend you consider testing, or a family member with pancreatic cancer. So what many providers now in the office, when they ask you what their family history, they can actually look at kind of these guidelines and see, do you meet criteria for insurance coverage? And if so, great, then you put it through your insurance. It's either a blood test or a saliva test. Or maybe you're someone that doesn't quite meet criteria, but you still feel like you want that knowledge because you have one family member who had breast cancer and you just want to know. And that's where that kind of out-of-pocket cost for doing genetic testing can be helpful.
Okay. Yeah. So helpful. Do you have any messages or a message that you would like to share with anyone who's listening who is potentially, going through breast cancer treatment, or they're trying to make a decision on surgery? Anything that you would like to share with anybody who's listening?
Yeah, I think I would say, first to start off, I would say, know that you're not alone in this journey. But on the other hand, everyone's journey is different. So it can be really challenging. Everyone, unfortunately, we're all prone to this, give people their kind of worst case scenario. And so I think trying really hard to know like that you kind of have to not listen to that noise a little bit about so-and-so's aunt and the things that they happened and what happened to them. Just know that, again, there's a huge community that's out there willing to support people at different stages and ages and surgery types. But everyone's journey is different. So try really hard not to know that yours is going to be that way. And then I think the other thing to know is like, there's another side to it. So I tell people the story about when I went through radiation therapy. I wore my running clothes every day. So I had 4 weeks of radiation, Monday to Friday, and I'd wear my running clothes to my radiation because I'd go running every single day after it. And I ran a 10K right after I finished my treatment. And, I think for people just to know, like, it's hard. I'm not saying it's not. I actually have my annual breast MRI later this afternoon, and it doesn't mean there's not anxiety in the back of my head, but you get to the other side, you're going to get to a point where you don't think about having breast cancer every day. And you're going to get to a point where you can do the things in your life that you love. And it is very disruptive, but it's not always going to be that way. And it can be very hard to feel that way when you're in it. But again, as a breast cancer surgeon, as a survivor, I know what it looks like on the other side. And knowing that you will get there, I think can be incredibly helpful for people when they're first diagnosed.
Oh, for sure. Thank you so much. And this was such a great conversation. I would love for you to share about your practice and how people can find you online and all the good things.
Thank you so much, Nicole. It's really, I just feel so grateful that you're including this and all of the other amazing topics that you covered. I like to do most of my education on Instagram. I think it works really well for plastics and breast surgery. So it's Dr. Dr. Anne Peled. So that's probably the easiest place. And then also Anne Peled MD is our website. Lots of information there. I love answering questions. So if stuff comes up, DMs are an easy way to do it. But again, I'm really, really grateful that you included me on this for your podcast.
Oh, thank you again so much. This was absolutely amazing information, and I'm sure it's going to be life-saving and possibly life-changing for so many who are listening. So thank you.
Thanks so much, Nicole.
That's a wrap. Be sure to click that subscribe button to join me for more Girl Talk Gone Menstrual in upcoming episodes. But in the meantime, check out my latest Period Party episode. And if you're looking for a deeper dive into your hormones, go ahead and take my period quiz at NicoleJardim.com/quiz.